from Jubilee Mission Medical College, Thrissur. Over to you, sir.
My dear friends, my topic today is adult congenital heart disease in pregnancy. Now, if you look at pregnancy and heart disease, a third of pregnancy-related deaths now across the world are from cardiovascular diseases. And the interesting, or rather the tragic aspect is that a two-thirds of these deaths are actually preventable. That tells us the importance of pre-marriage or pre-conception counseling to these patients. The reason is because the medical management, the surgical management of congenital heart disease has improved, with the result that more people, more women with congenital heart disease now survive to childbearing years and become pregnant. If you look at this registry of pregnancy and cardiac disease of large number of patients from 53 countries, 57% of all structural heart disease were congenital heart diseases. And even more interesting is that the number of high-risk pregnancies increased from 0.7% in 2007 to 2010 to a whopping 10.9% from 2015 to 2018. So you can see the rise in numbers in a few years' time, basically because these people are surviving now. Now, this has been discussed, pregnancy and alterations in cardiovascular physiology, I think have been discussed multiple times, but I will just put it short and talk only about two major hemodynamic changes. One is the fall in systemic vascular resistance, and the other is increase in cardiac output. Initially, there is a fall in systemic vascular resistance in early gestation. Blood pressure falls, that is good for the heart, because one of the major determinants of myocardial oxygen demand is at what pressure it is contracting. And so if the blood pressure falls, the myocardial oxygen demand falls, and most people tolerate the early part very well. However, things start changing by about 12 to 14 weeks gestation when there is a 50% increase in intravascular volume. A 50% increase in intravascular volume gets translated into a 50% increase in cardiac output. And so when the cardiac output is limited, either because of myocardial problems or because of valvular lesions, specifically stenotic valvular lesions, the volume overload cannot be tolerated and the patient goes into heart failure. So that is the basic problem. Regurgitant lesions are much better tolerated, but stenotic lesions are not. Now when you come to labor, the cardiac output further increases during the first stage of labor, and an additional 50% by late stage, which means by the late stage of labor, the woman's cardiac output is almost double what it was during the pre-pregnancy phase. And then during delivery, the vena cava obstruction is released, uterus contracts and pumps all the blood into the systemic circulation, and so naturally, in a heart which cannot tolerate this cardiac output or this stress goes into heart failure. And then there is another problem, that is the risk of thromboembolism. Especially in pregnancy itself is a prothrombotic stage. On top of that, if there is cyanosis, for example, which causes polycythemia, hyperviscosity, the risk of thrombosis increase. Or if there is a prosthetic material and the patient is on oral anticoagulation, again you have problems of thromboembolism. Atrial fibrillation again requires oral anticoagulation, that also leads to risk of thromboembolism. Now coming to adult congenital heart disease per se, the majority tolerate pregnancy well for the simple reason that complex heart diseases, unless they are repaired, do not survive into adulthood. So those who survive obviously have either been repaired or are not very significant lesions. True complex congenital heart disease, no doubt, have high risk for pregnancy and delivery. So pre-pregnancy counseling becomes very important. And to manage pregnancy and delivery, you require a pregnancy heart team, which includes the obstetrician, the cardiologist, the anesthetist, the intensivist, and maybe even a social worker. So it has to be a big team. The risk estimation is important because it has to be individualized, and the commonly used risk estimation tool is the modified WHO risk estimation tool. Probably the most important is the functional status of the patient. You must have heard of the NYHA class. NYHA class 1 means you are symptomatic only on more than normal exercise. NYHA class 2 is you become symptomatic on normal activity. Class 3 is on minimal exertion like say brushing teeth, and class 4 is at rest. So if the patient is NYHA class 1 before pregnancy, usually they degenerate into class 2 during pregnancy. So one stage is what is said. With the result that there are many people who believe that maybe a cardiopulmonary exercise testing before conception may be good, because if the patient's effort tolerance is good, forget about the lesion, they are going to do well in pregnancy and delivery. There are, of course, other things like LV function, severity of lesion, and history of previous events. And there are increased obstetric complications, premature labor, preeclampsia, postpartum hemorrhage. And a lot of drugs that affect the fetus, all these RAS inhibitors are given in patients with heart failure. All of them produce fetal renal shutdown. So that problem. And don't forget oral anticoagulant, which are also unfortunately teratogenic, especially at higher doses, especially in the first trimester. So genetic counseling, whether supplemented with further genetic testing or not, should at least be considered, because 10 to 30% of all structural congenital heart disease would have a genetic basis. Let me say a word about the modified WHA classification, which is very important because this is the one now used across the world. Class 1 is where the maternal cardiac event is very low, 2.5%, no increase in mortality, but increase in mild increase in morbidity, which are mild lesions, uncomplicated small PDA or a mild pulmonary stenosis or mitral valve prolapse, or maybe simple lesions like ASD, VSD, PDA, which are closed, which are successfully repaired, and arrhythmias like an atrial ectopic or a ventricular ectopic. So nothing much to worry about that. Class 2, 5.7 to 10.5% event rate. Here there is a small increase in morbidity and a mortality and a moderate increase in morbidity. Unrepaired simple lesions, ASD, VSD, or more complex lesions wise TOF, which are repaired, and arrhythmias other than occasional atrial or ventricular ectopics. Class 2 to 3 is 10 to 19% event rate with a significant intermediate increase in mortality and a moderate increase in morbidity. Mild LV dysfunction, mild left ventricular dysfunction, hypertrophic cardiomyopathy, repaired coarctation, bioprosthetic or new valvular heart disease not considered 1 or 4, at WHO 1 or 4. And aortopathies where the risk of aortic dissection is high, Marfan syndrome with an aortic dimension of less than 40 or a bicuspid aortic valve with an ascending aorta of less than 45. These are in general clubbed together as aortopathies. Class 3, again 19 to 27% with a significantly increased maternal mortality and severe morbidity also. Mechanical valve, basically because of oral anticoagulation. Systemic right ventricle, you know the right ventricle is tuned to pump into the pulmonary circulation where the pressure is around 15 or 20 millimeters. So when the right ventricle is supporting the aorta, is pumping into the systemic circulation with a BP of 120, it is likely to fail. And that happens in conditions like corrected transposition of great vessels, either surgically or congenitally corrected. So when the right ventricle is a systemic ventricle, that becomes class 3 risk. Fontan is when the inferior and superior vena cava are connected to the pulmonary artery, which means the right ventricle is totally bypassed. That again is class 3. And cyanotic heart disease, which is unrepaired, other complex congenital heart diseases, and aortopathies, bicuspid aortic valve, 45 to 50, and Marfan syndrome, 40 to 45 millimeter of aortic dimensions. And class 4, where the event rate can go up to 100%, 40 to 100%, pregnancy is contraindicated, extremely high risk of maternal mortality. Severe stenotic lesions, whether it is mitral level, aortic level, or beyond that, that is the coarctation. Bicuspid aortic valve with an ascending aorta of more than 50, or Marfan syndrome with an aorta of more than 45. Severe systemic ventricular dysfunction, LV or RV doesn't matter, severe systemic ventricular dysfunction. Patient who is very symptomatic, 3 to 4. Fontan with complications, and last but not least, significant pulmonary artery hypertension, whatever the cause is. All these are class 4 modified WHA classification. There are other scoring systems which I am not going into for want of time, and this is specifically for valvular heart disease. Now this is something new. You know, the natriuretic peptides are released by the atria and the ventricles when they are under stress. So nowadays, this is considered as a marker for heart failure. When you are not sure When a patient comes with breathlessness, whether it is heart failure or not, you look at the natriuretic peptide levels. Now in pregnancy also, when you check the BNP levels in the baseline and do it serially, it may tell you whether the pregnant lady's heart is under stress. Even normally, because the cardiac output is increased, there is a twofold rise in BNP. But this value of more than 128 picogram per ml of N-terminal pro-BNP at 20 weeks gestation has been found to be a very independent risk factor for cardiovascular events, especially negative predictive value. Look at that negative predictive value. If it is less than 128, you can rest assured that nothing is going to happen. 96% chance that nothing will happen. But of course, the positive predictive value is not very high. It is just 18.3%. Oral anticoagulation, another important problem in pregnancy. The newer oral anticoagulants like dabigatran, rivaroxaban, apixaban are contraindicated. But even the older ones, warfarin, produce warfarin embryopathy, especially in the first trimesters, especially with higher doses. But remember, it can happen even in the other trimesters also. So the recommendation is usually changed to IV unfractionated heparin, which is very difficult. You have to give it as an IV infusion. You have to repeatedly check the blood to see that APTT is more than 2 times. Or you can give subcutaneous low molecular weight heparin, where there are several unanswered questions. How do you monitor it? Do you measure factor 10A, which again is very difficult to do. And it has been found that when you compare warfarin with either unfractionated heparin or low molecular weight heparin, the risk of thromboembolism is definitely higher. So this is the recommendation. If the patient requires high dose of oral anticoagulation, shift to either heparin or LMWH in the first trimester in hospital. Second trimester, shift back to VKA in hospital again. And by 36 weeks, go back to intravenous unfractionated heparin or LMWH. 36 hours before delivery, change to IV unfractionated heparin, and 6 hours before delivery, stop unfractionated heparin and restart after 4 to 6 hours. Whereas, if the needed dose is less than 5 warfarin or less than 2 of acinocumarol, you can continue VKA in the first trimester. But remember, the rest of the management is the same. But remember, this can also lead to warfarin embryopathy. So what is required is a shared informed decision making, because it is warfarin embryopathy versus increased risk of thromboembolism. So that is a difficult question. That is why oral anticoagulation is considered to be very high risk in pregnancy. Post-delivery, you have to continue the intravenous or subcutaneous drug, whatever it is, along with vitamin K antagonist, because INR will take at least 4 or 5 days to reach the target value. So continue both for 4 or 5 days. Fetal risk. Fetal risk, the major determinant is maternal functional class. The higher the maternal functional class, the more the risk. Patients with severe symptoms, only 30% fetus are actually healthy. Another important factor is maternal cyanosis. If there is cyanosis but no pulmonary artery hypertension, actually maternal risk is low, but fetal risk is very high. And do not, of course, forget maternal medications, which I have already talked about. Left heart obstruction, smoking, multiple gestation, use of oral anticoagulation, again, all these are important risk factors. Now, if you want to intervene in the heart, either transcutaneously or surgically, it is generally advised prior to surgery. The only exception will be when you want to replace a valve, because as I said, the problems of valve replacement and oral anticoagulation. So in that situation, you have to think twice whether we can go through the pregnancy and then do the valve replacement or not. Cardiac surgery should be minimized during surgery. The maternal risk actually is not very high. The problem is the fetal risk due to cardiopulmonary bypass. And what about termination of pregnancy? When the gestation represents a major maternal or fetal risk, you require termination of the pregnancy. First trimester obviously is the safest time. Routine prophylaxis, this is very important. Routine prophylaxis for bacterial endocarditis is not recommended. But there are select high-risk patients where you require infective endocarditis prophylaxis. These are patients who have a prosthetic material or a device, at least during the first 6 months. Patients who have either repaired or unrepaired but have turbulence in the form of a shunt or a conduit, which produces a lot of turbulence and hence can produce infective endocarditis, or repaired CSD which still have some residual defects. especially if it is adjacent to a prosthetic device. And prosthetic valves definitely require infective endocarditis prophylaxis, and patients with a past history of infective endocarditis also requires infective endocarditis prophylaxis, but not routinely is recommended. Indications for cesarean, cardiac indications for cesarean, patients on OAC going into preterm labor, aggressive aortic pathology, Marfan syndrome, bicuspid aortic valve, aortic dimension more than 45 or 50, acute intractable heart failure, and severe pulmonary hypertension, whatever the cause is, including Eisenmenger syndrome. Last but not least, oral contraceptive. It has been found that the combined oral contraceptive is very highly effective, 99.9%, but the problem is the thrombotic stage, especially when there is a pre-existing thrombotic risk like cyanosis or a Fontan physiology or mechanical valves, and the patient is already on an oral anticoagulant, prior thrombotic events, and pulmonary artery hypertension, because already the pulmonary artery pressure is very high. A small thrombus producing pulmonary embolism can tilt the balance, because in a PAS, even a small embolus can be the last straw on the camel's back. So there again, you don't want to give an oral contraceptive. So this is the American Heart Association recommendations. Class 1, women of childbearing potential with congenital heart disease should be counseled about the risk associated with pregnancy and appropriate contraceptive options. And class 3 should not be done. Estrogen-containing contraceptives are potentially harmful for women with congenital heart disease who are at a high risk of thromboembolic events, which include cyanosis, people who had a Fontan's procedure, mechanical valves, prior thrombotic events, and pulmonary artery hypertension. So that is with respect to oral contraceptive. So I conclude here, these are the points that I want to make. Number 1, adult congenital heart disease is going to be an increasingly important problem that we are going to face. Oral contraception is important, but it is a very complicated issue. Preconception evaluation and counseling are probably the most important thing that we can do to prevent the 2/3 of the death which are preventable. The pregnancy heart team should be there in every hospital who deals with complicated congenital heart disease pregnancies. Risk stratification and individualization of protocols are of utmost importance, and these are the things which possibly tell you who are the high-risk patients. NYHA class, systemic ventricular function, stenotic lesions, pulmonary artery hypertension, aortopathies, and patients on oral anticoagulations. Thank you very much.
Thank you, sir. Thank you for that elaborate talk. Within that short time, you managed to cover all the aspects. I think the most important problem we usually face is people not disclosing the disease. They might not have disclosed it to their spouses also. So we always tell our PGs always to auscultate, first visit, proper auscultation, and nothing can replace a clinical examination. But still, if they are coming a little towards the end of the first trimester, already some functional flow murmurs might be there, so we might get confused. So do you feel like it might become a routine to do a cardiological evaluation for patients as a routine?
I mean, I agree with you that what is more important than maybe an echo or ECG is a good, well-taken history and a good physical examination. I think that cannot replace any other investigation. Otherwise, we will be unnecessarily investigating and creating more problems. So I think I totally agree with you. A good physical examination and a proper history should probably be the basis of deciding who should go for further investigation.
And sir, regarding IE prophylaxis, it's now only ampicillin alone, isn't it?
It is only ampicillin alone, no doubt.
Any other doubts? Thank you, sir. Thank you for that
Thank you.
excellent
Thank
talk.
you very much.